My name is Karen Stahlberg, and I'm a faculty member in the Department of Learning Health Sciences. And I'd like to welcome everyone to the Learning Health Systems in the Time of COVID-19 webinar. This webinar is being presented by the Department of Learning Health Sciences at the University of Michigan. DLHS is a basic science department in the medical school at the University of Michigan in Ann Arbor. Our faculty come from a variety of scientific disciplines and sciences, including the social sciences, information science, implementation science, computer science, simulation, as well as health care professionals. As a department, we unite around the concept of learning health systems and learning cycles. This 90-minute webinar is designed to introduce individuals to the overall concept of learning health systems, focusing on core components of the cycle, the infrastructure, and then providing an example of how that was used in real time. Several faculty members will be discussing the cycle and describing how those scientific principles were applied to the COVID pandemic here at the University of Michigan and Michigan Medicine. Next slide, please. Just some minor housekeeping issues. As you know, when you've checked in, this session is being recorded. The link will be shared with participants a few days after the webinar. Additionally, CART services are being provided, and in order to access, please select the CC or closed caption button at the bottom of your screen and select Show Title. After the presentations, we will also have a Q&A session followed by the panel discussion. So while the speakers are speaking, please feel free to use the Q&A tab to enter your questions, and we'll make sure to circle back after the end of all of the presentations. Next slide, please. So we have really a wide array of amazing talent to present today, leading off with our chair of the department, Dr. Chuck Friedman, to talk about learning health cycles. We will then move to Dr. Karandeep Singh, who will talk about COVID at Michigan Medicine. Next slide, please. And how we can make computable knowledge shareable. We'll then continue around the cycle with Dr. Ann Sales talking about the principles of implementation science. Next slide, please. As well as talking about ethical and policy issues with Jody Platt. And I skipped a stage in there as well with my colleague Alan Flynn, and for that I apologize. Like I said, we'll get to Q&A as well as a panel discussion after all of the presenters have completed. Next slide. And this is the lineup that's featured at the end of the discussion. My colleagues and we'll go through again at the end, but again, providing reflections, thoughts, next steps. And next slide. And so now to hand it off to our esteemed leader, the chairman of the department, Dr. Chuck Friedman.
Thank you, Karen. Greetings, everyone. And on behalf of our department, I want to thank you all for joining us on this webinar today. Next slide, please. As you'll see on this slide, our initial presentations are anchored in the concept of the learning cycle. And the learning cycle is absolutely fundamental to the operation of learning health systems. The cycle begins, if you look to the lower right of the slide, with the formation of a diverse learning community. And that community forms around a health-related problem that is of profound interest to that community. Typically, the members of the community will share that sense of imperative, what may even be called a passion, to solve the problem, and this strong motivation among the members of the committee is to a very large extent what drives this process forward. The community then engages in a cyclical process that begins with P to D, which is performance to data, and that is the activity of systematically studying and generating data describing the current situation with regard to the problem of interest. The cycle then continues as we move along clockwise with D to K, or data to knowledge, where the community uses these data to develop insights into how the problem might be addressed. Next, as we continue clockwise in K to P, knowledge to performance, the committee determines how to implement these insights and then takes concrete action to address the problem of interest. This is an implementation. Then as the cycle enters its second iteration following the implementation, data are collected about this now changed and hopefully improved system, which begins the process of further improvement. It's important to emphasize, and this is a significant point of departure for learning health systems, that the same learning community executes the entire cycle from P to D to K and K to P and onward from there. There are no handoffs from one discrete group to another. Next slide, please. In today's webinar, as Karen said, we turn to the challenges of the current pandemic and introduce a specific problem of interest. This problem is the challenge of, as the pandemic spread, how to identify patients who could be safely situated in a field hospital, which appeared for a time, as you will hear, as a step that Michigan medicine was going to have to take in response to the pandemic. This problem required learning and implementation of extreme importance and at a very, very rapid pace. Next slide, please. Many of us believe that the COVID-19 pandemic issued for the entire world a clarion call for more robust learning systems than we currently have in place. At the same time, our execution of pieces of the learning cycle gave us more than a glimmer of what might be possible when a more robust system is in place. Against this backdrop of the learning cycle, our 4 presentations to follow will be a mixed narrative of events that did happen in our COVID-19 experience and what can happen in a hypothetical future where a more robust system is in fact in place. Each presentation will be keyed to a specific phase of the cycle, as I will illustrate now. Karandeep Singh will begin by introducing the problem of interest around field hospital placement and then describe our data to knowledge experience, which is why his talk is noted at that point in the cycle, of validating an existing prognostic model with our local data. Then in COVID-19 context, Alan Flynn will transport us a bit into the future by envisioning a day when the knowledge generated by the learning health system will be both computable to enable its rapid deployment and shareable so that organizations in a large-scale pandemic can benefit from each other's efforts. Following Alan, and using our COVID-19 experience as a point of departure, and sales will focus on the knowledge to performance piece of the learning cycle and how principles of implementation science can ensure a more successful application of the new knowledge. And then to close the series of presentations, Jody Platt will remind us that learning health systems are people systems, much more than they are cyber systems, and will introduce us to ethical principles essential to the work of learning communities and to learning health systems as a whole. So now it's my pleasure to turn the presentation over to my colleague, Karandeep Singh.
Chuck, thank you for that introduction. I'll start by talking a little bit more about the background on how we came to select this problem of interest, giving you some context both locally at Michigan Medicine, as well as a little bit of context from information that was things that were happening across the state. Next slide. So although our first patient with COVID-19 arrived a little bit sooner than that, by March 16th, it was pretty clear that we were going to be seeing an influx of patients with COVID-19. March 16th is the day that we activated a regional infectious containment unit, which is a unit in the hospital comprised of negative pressure rooms that was designed to care for patients with COVID-19. Place for what to do when that unit started to fill up with these patients, which included doubling up on the rooms, sending patients to other wards in kind of a stepwise manner across the health system. But this is kind of the time where we were starting to recognize we were going to be seeing a substantial influx of patients. Next slide. About 2 weeks later, on March 31st, the situation appeared pretty serious. If you look at that red arrow, which shows where we were on March 31st, and you look ahead, even under a best case scenario, which is represented by the yellow line, there was a thought that we were going to reach a peak census of about 3,000 patients. And as you may know, our hospital's capacity is approximately 1,000 patients. So when dealing with this thought that we may be seeing a hospital census that is 3 times what our hospital can handle, a lot of very serious, important decisions had to be made about how we were going to care for these additional patients. Next slide. So one of the questions that arose at about that same time that we were making those decisions was that we may need to open a field hospital. Obviously, we were going to be seeing more patients than we'd be able to handle. And so opening additional places to care for patients was certainly one way that we could accommodate those additional patients. And then very closely linked to that question was which patients should go to a field hospital. So on March 31st, some of our executive leadership talked about which patients might be appropriate. And the thought was that the field hospital would serve potentially as a step-down unit for patients who were generally stable, but not stable enough to go home. So the idea was patients who were sick would come into the main hospital, we would care for them, make sure they're stable, and then once they're stable, they would be able to be transferred to a field hospital. Next slide. Now, obviously, just to give you some sense of context, we weren't the only ones in the state thinking about this. At the time that University of Michigan was considering opening a field hospital, 4,000 beds had just been approved across the state of Michigan to care for this patient population. Now, part of this was because of the fact that Michigan was among the most hardest hit states at that time, both in the number of new cases of COVID-19 and in the number of deaths being seen from COVID-19. So opening these new hospital beds was of paramount importance from the perspective of where we sat then with the information that we had. Next slide. So recognizing that we were going to see potentially a census of 3,000 patients and that we had the capacity and staff and clinicians to care for 1,000 patients under usual circumstances, we were going to have to make triage decisions about which patients to send to a field hospital under suboptimal conditions. We wouldn't be able to spend as much time with these patients as we potentially usually do to make these decisions. And so a question came up at the level of the command center, scarce resource team, which was, is there any tools out there? Are there any tools that we could use to help make these kinds of decisions? And specifically, the types of tools that we were thinking about were predictive models. A predictive model is a tool that takes a set of predictors, predicts the probability of an outcome. And in this case, there have already been dozens of predictive models developed across the world from places like China and Europe that had seen cases of COVID-19 prior to the US that were developed specifically in COVID-19 patients. Now, unfortunately, there was a systematic review published in the British Medical Journal showing that these models, by and large, were quite biased, mostly because they were developed using very small patient populations, because no individual center had sufficient sample size of COVID-19 patients for it to be representative, and because of a variety of other modeling decisions. And so we felt like the models that were available in the literature, specifically for COVID-19, just weren't going to work, and we ourselves didn't have the sample size yet to develop models specifically for this reason. And doing so could have caused harm, which is why we decided not to do it. Next slide. So one important alternative to this is if you don't have a model that you can develop from scratch because you don't have the sufficient sample size, is to take something that's similar, that's already in use, and to kind of repurpose it or validate it to see if it would work for this kind of problem of interest. And for this particular problem of interest of who should go to a field hospital, we wanted to send patients to a field hospital who would not need ICU level care. And so we looked at this epic deterioration index model as a potential candidate model that could help us find which patients would not need to go to the ICU. Now, we weren't the only ones looking at this model. Epic, as you may know, is a large electronic health record vendor in the US. There are a large number of health systems in the US that use that electronic health record. And so many health systems across the country were looking at this deterioration index model as a potential way of triaging patients with COVID-19. Although this model is proprietary, which means we know what variables go into it, but we don't know exactly how the model is represented. It's widely implemented across the US. It's estimated to be in place at over 100 health centers. And so we thought this was a good model for us to look at because we had it available, it was widely used, and we could readily calculate it on our patients, even if it wasn't something that we could readily share. I will point out here that we can come back to in the panel is that this is a model that may not be available to all patients because of the fact that it's proprietary and because the electronic health record vendor that it's using is a product that not all health centers have. And so that may impact how this tool might work elsewhere, but we felt like we had access to it, so we should look at it first. Next slide. So with that bit of background about the problem of interest and the context for predictive models, I'll talk now about how we went about validating the Epic Deterioration Index model at Michigan Medicine using data that we already had. Next slide. So when you enter a learning cycle, you've got to start with a learning community because you need to know who's responsible for what and who are the key stakeholders. And I would say we had a set of loosely overlapping learning communities or groups that kind of were participating at various different levels in this learning community to answer this question. On one hand, at the very top, there was the Michigan Medicine Command Center. And within that command center, there was a scarce resource team that was in charge of figuring out what we would do if we ran out of things like hospital beds or if we were running low on supplies like protective gear for clinicians. So they were, I think, the ones who had posed this question and were actively involved as we went through our analysis. There was the COVID-19 analytics team, which is an operational team that was put together, bringing together many different data and analytics groups at Michigan Medicine who normally would meet separately, kind of bringing them under one roof, meeting several times a week over the course of the first 2 months of this crisis to try to answer these questions and do some rapid cycle learning. There was also the Division of Hospitalist Medicine, whose chief was actually involved in some of the decision making and involved in some of the dissemination of the work that we found that Ann Sales will talk a little bit more about in her talk. And of course, there was researchers who wanted to learn more about how they could help and what they could learn from this. And so all of this analytical work was also being coordinated with the Data Office for Clinical and Translational Research to make what we were learning also available to researchers as a separate thing, not part of our learning cycle directly. Next slide. So what is the Epic Deterioration Index? Well, simply, it's a model that was developed between 2012 and 2016 using data from multiple healthcare organizations across the country. And it pulled in data from over 130,000 patient encounters. It was developed to predict a composite outcome of the need for resuscitation, need for a patient going to the intensive care unit, or for experiencing in-hospital death. It was based on several predictors, including the ones that are shown on the screen below. What I will say is that some of the predictors, like age, are things that are probably going to be constant over the course of your hospital stay or not change substantially to the extent that it would affect the model. And other things like vital signs or your oxygen requirements, or even the nursing assessments and labs, we would expect to change pretty rapidly. And so as these elements change, the prediction model score would also change over time. Next slide. So what the score gives you is a number from 0 to 100, where 0 is telling you that you're at low risk for experiencing one of those outcomes, and a score of 100 is a score that tells you you're at very high risk for needing resuscitation, going to the ICU, or dying in the hospital. It's not a score that you can interpret as a probability, but that's kind of the rough range and what the numbers mean, at least generally speaking. We happen to have been running this score in the background on all admitted patients since late 2018 at Michigan Medicine. And so even though we had been running in the background, we weren't making any decisions based on it. And so what we didn't know was what exactly do the numbers mean? And we also didn't know what we should do with the numbers. And but when I say I don't know what the numbers mean, I guess what I mean to say is, if you had a score of 40, what does that actually mean for that patient in front of you? That's a data to knowledge problem that we try to solve. And then there's a separate question, which is related, is once we have that score of 40, what should we do for that patient? And that's a knowledge to practice problem that helps us figure out what we should actually do. And so I'll talk about that first part, And sales will be talking a little bit more about that second part and what we can do. Next slide. So here's what it feels like to use the deterioration index in clinical practice. And this is 4 patients with COVID-19 who were scored by the deterioration index over the first 48 hours of their hospital stay. Now, I told you a score of 0 means the patient is low risk. A score of 100 means that they're high risk. And this color coding was something that Epic, the vendor, doesn't provide to us, but that we added after the fact, just as a visual aid. Now you can see that this first patient, patient 1, had a score that was bouncing all over the place. They came in the green zone, went to the yellow zone. But if you were a clinician caring for this patient, you could imagine how almost every 15 to 30 minutes, this patient's score is going to be wildly different from what it was kind of moments before. Then you have a patient like patient 2, where their score is kind of lowish, and it remains low for the course of their hospital stay. And then they're able to be safely discharged. And then patients 3 and 4 are patients who both needed to go to the ICU. Patient 3, you can see how they came in with what was looking like a very reasonable, not too high of a score in the kind of yellow area. Then their score peaked at about 75. Then it came down, so it looked like they were getting better. And the next thing you know, they went to the ICU, and eventually they had to be started on mechanical ventilation. And then patient 4 basically looks a lot like patient 1, except for the fact that for patient 4, they ended up needing to go to the ICU, whereas patient 1 did not. So you can see how maybe this score has a little bit of face validity just from looking at these trends. But there was a real question of how this score could potentially be useful because of this fact that your most recent score doesn't seem to necessarily track with how sick you are or whether you need to go to the ICU. Next slide. So we looked at the adult patients who had come in with COVID-19 to one of our general care units, so not to the ICU, in the first month of March and a little bit into April. And amongst the patients who had been in the hospital for at least 48 hours, we looked to see, could we use this deterioration index to figure out which patients wouldn't experience an adverse outcome for the rest of their hospital stay, and thus could safely have gone to a field hospital had we needed to triage them to a field hospital. Next slide. So what did we find? So after running this analysis on the first 109 patients that we had who had to be hospitalized for at least 48 hours, we found this area in this green zone where patients in this green zone had a 93% negative probability. What that means is that for these patients who were persistently had a score below 37.9, which put them into that green zone, only 7% of them would need to go to the ICU for the remainder of their hospital stay or would die for the remainder of their hospital stay. And after we talked to the command center, we felt like if we truly were in a scenario that was a catastrophic disaster scenario where we were at 3 times our hospital capacity, that 93% negative predictive value is probably good enough to say that we can safely send you to the field hospital. Now, unfortunately, that score only applied to about 13% of patients of what was a pretty small cohort. So we felt like this score was better than not having this information, and particularly in the fact that we weren't seeing these patients as often as we were seeing regular patients. If we were to have had an influx with a huge surge, we felt like this would have been useful to triage our patients with COVID-19 coming into the hospital. Next slide. So our findings in code are available. We were very quick to release this information and all the code required to produce this kind of analysis to the public and to the scientific community for further comment. And so our paper is available on the left and the code is available on the right. Next slide. So one thing I did say in my talk, though, was that the EPIC deterioration index is a proprietary model, which means that even though we found something that potentially was going to be useful to other health centers could only use it if they were able to have access to the proprietary code. So now I'm going to turn it over to my colleague, Alan, to talk about what could have been different if we had the ability, when we found a model, let's say we found a model that was perfect, to be able to rapidly disseminate that model in the form of computable biomedical knowledge.
Thank you, Karen Deep. And good afternoon, everyone. It's a pleasure to be with you. Thank you for joining us today. As Karen Deep said, I'll focus on a certain aspect, a certain part of the knowledge to performance portion of the learning cycle in my comments today. Really, the focus is on making computable knowledge such as a predictive model, shareable for learning health systems. Next slide, please. So I want to begin by reviewing the story that was just shared by Karen Deep, but with a particular focus on the shared predictive model that was used to potentially classify COVID-19 patients into a high versus a low risk category for complications and deterioration. The complications including resuscitation, the need for ICU level care, and death. So remember those 4 patients and then multiply by a large number. We had many patients whose data were ultimately shared and processed at Michigan Medicine with this particular COVID-19 model. And in my slides today, the predictive model, there's an icon that I used for that, which is essentially supposed to represent a number of variables and their relationships to each other that form the actual model that is then used when processing data to generate scores. So data come in from patients. The model is applied to those data, and we do processing of those data, ultimately to generate the scores, as Karen Deep said, from 0 to 100, in this case using the deterioration index. And then the goal that we had was potentially to categorize individuals into a higher risk category or a lower risk category. And remember, the background for this is that there was concern at this time that we would need to open up a field hospital. And so identifying those individuals who were at low risk for needing ICU level care or needing ventilators was important. And so the idea was perhaps this model could help sort out in a systematic way those individuals who are at the highest risk so that we could provide hospital care for them at an increased service intensity. And while for others at a lower risk, providing normal care at a normal service intensity, not ICU care in a field hospital. Of course, when we put a model like this to use in general terms within a healthcare process, we need to then study the outcomes of actually using the model. And so at the far right of this slide, what we're pointing to there is that once we've categorized individuals and applied an intervention or different services, we need to then understand in the context of a learning cycle whether our approach is better and an actual improvement in the way that we provide care. Next slide, please. So Karen Deep began to tell the story of how well the shared COVID-19 model that was used at our site, but as he said, was also used at perhaps 100 other locations. You know, how well did that work in our patient population? And so the study that was published reports data at a cutoff of 64.8 for determining whether an individual would be categorized as high risk according to the deterioration index scoring model or low risk. And Karen Deep gave some of the results in that paper. Additional results are also provided. The overall result, the researchers determined that the performance of the model in the patients that the Michigan Medicine was taking care of was so-so or fair. And by setting the risk threshold at 64.8, there was an 80% positive predictive value and a 39% sensitivity. And remember, sensitivity is the true positive rate. So those individuals who indeed did need that intensive service of resuscitation or ICU care over the total population. And so you can see that in terms of its performance in our population, you know, the model was far from perfect. but we never actually got to outcomes from using the model. And that's because in our implementation here, the model and the scores that you saw were made available on an opt-in basis to clinicians who were interested in seeing those graphs, but we did not have a systematic deployment of the model. Click, please. So the point here that I want to reiterate that Karen Deep made is that in a time of COVID-19, to be able to take results and outcomes from multiple sites would have been helpful. And to be able to combine data across multiple sites, we might have been able to go a little bit further. Also, to have more transparency into the way the model is built and the way it functions is something of interest to us from this story, and not only to us, but others have published on the need for that as well, and there's one publication listed here. Next slide. So very briefly, I want to generalize now this idea of computable models and why we must share them to have learning health systems. So the model, as I said, that strange looking icon of relationships between variables on the left, we had one example in this story, but of course there are many different models coming from machine learning and AI and other types of scientific work that we can potentially use throughout biomedicine and in healthcare. These artifacts, these models are sometimes called knowledge artifacts or clinical decision support, CDS artifacts, knowledge objects, and so on. And examples include predictive models and Bayesian decision models and the other things you see listed there. Click, please. So with all of these models that we can potentially use, we value them from a learning health systems and learning health cycle perspective because they are computable and they can be shared potentially on a widespread basis to provide information to many, many people. But for learning health systems, in order to complete learning cycles effectively and actually improve care, we're going to need to share and apply computable models in systematic ways and on large enough scales that will enable us to learn something. Next slide. So my final slide is a list of considerations for computable model sharing that are related to today's story and related to our work here in the Department of Learning Health Sciences. And many of these considerations come from a paper that's listed there from Harold Lehman and Stephen Downs, but others come from our work here, in this case and other cases, of using predictive models in practice or starting to. So to finish my comments, I'll just make a few comments on these 14 items here. There's not time to go through all of them. But one of the themes of today's presentation is that many stakeholders with technical, clinical, operational, quality improvement, and education backgrounds are needed in order to bring prediction into practice using these kinds of models. Another point that's now been made a couple of times is that access to the models and transparency about how they work is something that's of great interest. In this case, we're working with a proprietary model. We also sometimes get to work with open models, and we really value that transparency. Local calibration and setting of thresholds is clearly important. Here we had a model already running. We had to gather data in order to do validation, and we needed to follow some procedures to do that work and to do it well. Finally, designing, developing, and evaluating interventions is important additional work that my colleague Ann Sales will be talking about in a moment. And librarianship and mobilization, listed at the bottom of this slide, are two other very important aspects of this work. Librarianship is key for managing many computable models, and mobilizing models is all about developing computable model management as a subfield of learning health systems science. And for this, we have the mobilizing computable biomedical knowledge community already at work to try to help in these areas. Next slide. So I'd now like to turn the presentation over to my colleague, Ann Sales. Ann?
Great. Thanks very much, Alan, and welcome everybody. Just before I start, I'd like to remind everyone that we do have the Q&A box, and suggest that if you'd like to go ahead and add questions now. We'll be taking questions after Jody Platt's presentation, which comes after mine. So in the next few slides, I'm going to focus on how implementation and its practice can support rapid but systematic approaches to implementing a new piece of knowledge and using the deterioration index that we've been talking about as an example. Next slide, please. First, I'd like to briefly describe how the deterioration index was actually implemented. Educational materials shown on the right-hand side of this slide were sent through usual channels, which include email, going through clinical leaders, department leaders, and presenting people with a nice, concise document that you see there on the slide to give information about what the deterioration index is, how they would view it, and what they would ideally do with that information. They were asked to add the deterioration index score, which I note, for an individual patient, the one that they're taking care of at the time, to their sign out for oncoming shifts. They were also asked to look, though, at the trend line over time in the dashboard that's at the lower right-hand part of that flyer, and assess the trend across time, then incorporate that into decision-making, both through rounding and discussion of the patient, and also focusing on the handoff between oncoming shifts and thinking through longitudinally over time for that patient. This all reflects what was actually done in the context of really very rapidly changing and highly pressured situations. There was no formal evaluation of whether the score was used, although informally, we have learned that some hospitalists are still using the score, even though at this point in our hospital, the surge has died down considerably. Next slide, please. Moving on to how we might approach implementation of the deterioration index using tools from research. First, a brief definition. We define implementation as a process of planned behavior change under organizational constraints. We'll discuss the major components of this definition operationally and how they fit the deterioration index as an example. It's important to stress that these processes are systematic and they build on the existence of a learning community formed around a primary health problem of interest, as Chuck and Karandeep and Alan have all stressed. In this particular case, the health problem of interest is how to identify patients who could safely be moved to a field hospital during a pandemic surge. The new knowledge here is the deterioration index, which we have to note is still in development. It is still has not been fully tested across multiple sites in multiple contexts, but it was used at Michigan Medicine during the most recent period. And so we'll talk more about how fuller implementation could happen. Next slide, please. So the first thing that we would do in implementation would be to focus on the nature of the behavior change required to implement the deterioration index. First, we identify the key stakeholders, the people who are affected by or need to use the deterioration index score and or aggregated data. Here, we follow the logic of the definition that I gave. Whose behavior needs to change? This gives us a list of key stakeholders on the left-hand side of this table. How often does that behavior need to change? Where would the change happen? When and in what circumstances would it occur? I want to note that a large number of the stakeholders that I identify are frontline bedside providers, and others are at higher levels of the organization or even beyond into the region or the state. It's important to note that frontline providers need to know details related to individual patients, while at higher levels of organization, the more important information is aggregated. Critically, nurses caring for COVID-19 patients need to ensure that the data that are used to calculate the score are accurate and current. Physicians need to ensure that they know the score, can see it and observe it, and include it in the care planning that they're doing. Next slide, please. A very important part of the systematic process of implementing an innovation is to identify relevant, important, and modifiable barriers that will make it difficult to change behavior. Some of these apply to all stakeholders, while others only apply to specific groups. Once the key barriers are identified and vetted by the stakeholders, we identify strategies for overcoming them. I note that two in this case might be particularly important and highlight those in red. The time pressure that overloaded clinicians are under and the concern about autonomy and the ability to use clinical judgment. The strategies used to overcome these two barriers may be used at different times. Rapid learning to help inform people under intense pressure needs to be deployed at the outset of implementation, while the need for open dialogue about clinical autonomy can and perhaps should happen over a more extended time period. I want to also stress that we wouldn't deploy all of these strategies. We would choose among them and, as much as possible, engage stakeholders in deciding which strategies to try first. We also need to evaluate the effect of each of the strategies that we use, because even though there may be evidence in the literature for how effective a strategy is, or we've used it before and we know how it works, we need to understand how it works in this particular instance. Finally, we need to ensure that we conduct a summative evaluation to help us learn how the deterioration index works, under what circumstances, and for whom. As Karandeep noted, there's little information available on this in the literature at this point, and we can add substantially to our practice knowledge and to the literature. Next slide, please. Two final notes that I'd like to stress about implementation. The first is to understand and engage with stakeholders. All of the people I listed and more should be part of the learning community around this health problem of interest and should be engaged as data are extracted, analyzed, developed into knowledge and knowledge objects, and then used. In implementation, engagement of stakeholders is essential, although different people may be engaged in different ways at each of the steps. Inclusion is a key principle, and figuring out everyone who plays a role is critical. Finally, it's essential to evaluate what happened. A very important question in this example is how the deterioration index performed in identifying lower risk patients and what the outcomes were for people who were identified. However, we also need to know whether and how the strategies we used worked, as noted on the previous slide. It's impossible to close a learning cycle loop without evaluating what happened and figuring out what the effects of the work were. The data generated through use of the deterioration index become the data available for the next learning cycle, allowing us to think more deeply and potentially address new and different questions from the original one that we started with. Next slide, please. To end this section, I just want to reiterate the overall goal of all of this work is to achieve the best outcomes possible for the patients that we provide care to. Understanding what did and did not work is essential to achieving this goal. Moving into the next cycle is essential to having a fully functional learning health system. In all of this, there are important concerns related to policy and ethics that Jody Platt will discuss next. Next slide.
Okay, thank you, Anne, thank you all for being here. As Anne just mentioned, I'm going to talk a little bit about the ethical issues and touch very briefly on sort of policy questions for learning health systems in the time of COVID. You can go to the next slide. I'll consider the question that we've been talking about for the past 45 minutes about the allocation of scarce resources and the being able to have ICU available for people who need them and in a timely manner. But I also want to sort of broaden the question of what are the ethical questions that we're asking, and are they the ones that will ultimately achieve the opportunity of a learning health system, which I see as being sort of an innovation that can build a better system than the one we have now. So next slide. So we're going to look at the sort of big ethical, some big, some little ethical questions that we've been thinking about for a while, even before COVID, from the perspective of three different stakeholder groups that form part of learning communities at any given moment and have been a part of some of the discussions that we've been talking about so far today. We'll consider the perspectives of professional caregivers, the people who need care, and bioethicists, and think about what kinds of ethical questions are they grappling with, both before COVID, but also since the onset of the pandemic a couple of months ago. Next slide. So before COVID, learning health systems was an innovative idea. It still is an innovative idea, but it raises questions for professional caregivers around how will the technology impact the way I'm able to sort of practice my my trade, and what will happen to the art of healing, the art of medicine. Next. For the people who need care, we've heard concerns about, will I be treated like a number? Will all of this focus on data and numbers sort of supersede any listening that might happen about the specific concerns I have? Whenever you're sort of making data bigger, there are questions of privacy that emerge, and will that decrease privacy ultimately cause me harm? People who still need care are also going to wonder if they can get care and if they can trust others with their information. While bioethicists have been raising the question of whether sort of where does research begin and where does clinical care begin in the context of learning health systems. And there's a nice framework that was written up by Ruth Faden and colleagues at Johns Hopkins, if you're interested in learning more about that debate. But those were the kinds of questions, the ethical questions before COVID-19. Next slide. And so after COVID-19, next, all of these questions are still out there. None of them have been resolved, but we begin to add on to them. So for professional caregivers, next. We can see, they're still asking what will happen with the art of healing, specifically if they can't see patients, if patients aren't seeking care. A lot of people have had to learn very quickly about telehealth. But there are also questions about whether they can trust the numbers, whether the studies that are coming out are relevant, what are the best practices. And I think we've learned some interesting new things that are happening in Michigan medicine around that. Next slide. For patients and people who get care, again, same questions, but then there's also sort of another dimension here. So privacy had one set of sort of issues and concerns before the pandemic, but now there are sort of debate in the ethical world about whether there's actually a moral obligation to use health apps for contact tracing and things like that. And so maybe, there's a new edge to what privacy means to people. And the question is even more salient now than ever. Will I still get care, but also will my family get care? Will my community be cared for in the context of COVID-19? And for bioethicists, the immediate first question was, what is the fair allocation of scarce resources? How do we allocate beds to people when we might not have enough? And a lot of those questions came down to a recommendation that we look at how many quality years of life people might have left to determine whether or not they would receive a ventilator, for example. And again, that sort of, if you go back to the patient question, makes that very real. Will I get the care that I need? And we've heard from the disability community in particular that kind of allocation made them feel less than valued. Next slide. And this begins to sort of open up a whole nother set of questions that we'd like to sort of frame as the social ethical questions for learning health systems in the time of COVID. So for professional caregivers, that might be questions of, what is my responsibility? What is our responsibility as caregivers to address the inequities and the large disparities that COVID-19 has underscored? It's important to realize that these disparities existed before COVID, but that we've sort of shined a bright spotlight on them. Karen Deep talked a little bit about sort of the potential for small sample sizes and other sort of early models to potentially amplify racial and other biases, and then also to sort of wonder from the caregiving perspective, are the people who need care the people who are getting care? Are they my patients? People who need care may wonder if they're being heard, if they're being seen. And again, that applies not only to individuals, but to communities and entire sort of groups of people. And as bioethicists, can we address the structural injustice and racism in our health systems? Next slide. So all of this to sort of raise the question, that's what ethicists are good at doing, is to ask, to what extent is our learning health systems, or when is a learning health system asking the right questions, and when does it need to move the spotlight? So the streetlight effect refers to the old story that, somebody loses their keys and they get, somebody asks why they're looking for them under the spotlight. It's not that they dropped their keys there, it's that that's where the light happens to be. They actually dropped their keys a few miles back upstream where it's still dark. So I think anyway, I think it's an apt metaphor for what we don't want to happen. And again, the opportunity for a learning health system to expand the set of questions and engage a broader set of communities in answering, if not answering, at least raising important questions. So again, so many of the people that are affected by COVID are vulnerable population. They're the nursing home residents, they're African American, there are neighbors and others who are really sort of a different type of frontline worker. Next slide. So policy development is sort of a place where we can begin to do things about this. And a definition of policy development that I've always sort of liked is that it links science and evidence with the political, organizational, and community values to set a course of action. So any policy, whether that's a policy of inaction or a very complex multi-page thing, is ultimately sort of it ultimately is a reflection of the values that that society has towards its most vulnerable and towards its least vulnerable. So with that, to think about sort of what types of actions we may be able to put forward, and to underscore that there's an ethical obligation to close the loop, to collect the evidence that's that we might not have, and to understand what the effect is of the interventions that we do make. To expand the loop, not only under the spotlight, but outside of the spotlight. And if there's no spotlight there, we can turn a light on. And to think about sort of bring with us a greater awareness of the social implications of our work in health and healthcare in order to earn the trust of the people we most want to serve. And with that, thank you very much. And Karen, I think you have the mic.
Thank you. So that was a very quick and impressive trip around the learning loop. As you can see, there are a number of questions already in the Q&A text box. What I'd love for you to do right now as a participant is to go ahead and get your additional questions in. We'll start with the ones that were already brought forward and continue to move from there. We're doing pretty well with time, and so we're going to allow a little bit of time for a question and answer, and probably in about 15 minutes, then move forward to a reflection piece. And I want to make sure, I like to call out people when they come up with the million-dollar questions, and I think Ronald Willis has one in the Q&A, which will help lead me into our reflection and discussion. So I'm going to hand this over to Emily Coulter-Thompson, who's one of our colleagues, to help manage the Q&A.
Thank you, Karen. We'll start with the first question for Dr. Singh. Did you calculate any of the other predictive modeling tools to estimate risk for comparison with other proprietary EPIC tools? Examples given were Apache, SAPS, Rothman Index, etc.
Yeah, thanks for the question. And I think the first two questions I answered in the chat box, but I'll go ahead and answer out loud anyway. We did look at other tools. We looked at another tool by EPIC, which is the EPIC sepsis model. The reason we looked at that, even though it was intended for a different purpose, is that one of the limitations of the EPIC deterioration index model as currently implemented is that it only starts scoring once a patient is admitted. And we wanted to see if we could have a score that starts from the moment a patient arrives in the ER. So that was one that we looked at, but we found that the EPIC sepsis model didn't have nearly the same discrimination or performance for identifying patients who need ICU level care as compared to the deterioration index model. We didn't look at Rothman, although there's a lot that's been written about Rothman. I think there was a New York Times article on it. There's publications on it. It's not widely available because it's distributed through a company called ParaHealth. And since we currently don't have a contract with ParaHealth, it's not a score that you can readily implement. And so that we just happen not to have it. We did look at other ones like SOFA score was another one that we were considering. So I think the deterioration index is one we did the kind of deepest dive into for a variety of reasons, but we did look at some other ones that we already have calculated. We had about a 2-week span from when we were told we need something to when our field hospital was projected to open. So we looked and prioritized things that were already implemented as opposed to trying to build new things in or building things out in different environments that weren't already available in those environments.
Thank you, Dr. Singh. This next question is for you as well. Does EPIC update the deterioration model algorithms? And if so, how would you adjust?
Thanks. That's also a great question. To the best of my knowledge, it has not been updated. The EPIC does provide documentation to institutions that use their electronic health record describing each of the various tools. And as far as I can tell, I think it's the same cohort it was developed on back in 2012 to 2016 that they're using today. Although I could be wrong on that. One thing that question brings up, which I think is really important, is the idea of versioning when you have computable biomedical knowledge. Unlike things like, even books have editions, right? And so when models change over time, you need to be able to know what version of the model you're using. And if major changes happen under the hood for how the model works, even though the model is the same name, it might be something completely different from what you were using before. So certainly we don't think the version changed while we were using it, but I think it's still the original model to the best of my knowledge.
All right, and a couple more for you, Dr. Singh. Considering the small sample size of your validation study, are you planning to update your study in the near future? And paired with this did you also assess discrimination, the AUC, CSTAT, and calibration? Do predictions agree with what was observed for individual patients?
Thanks. I think that question was from EWOUD, and thank you for participating in that systematic review. I think it adds a lot to the literature. And I know it was just updated, I think, yesterday or like in the last couple days on BMJ's website. So to answer your question, yeah, we actually, I just got updated data yesterday for a much larger cohort, which represents kind of the next several patients. So I think our cohort will at least double in size and we'll have that available as a preprint and hopefully in a journal at some point. The other question around C-statistic, yeah, so actually if you read the preprint, we have a lot more detail in there than what was covered here. The C-statistic for the model overall was about 0.76. If you use it for the purpose of what I presented today, which is you throw out the patients or you exclude the patients who were, had an event in the first 48 hours or were discharged in the first 48 hours, the C-statistic is a little bit lower. It's, I think, closer to 0.7-ish or 0.68. And yes, we looked at calibration. As I mentioned earlier, even though the score is 0 to 100, like we don't know what it means. Is it some kind of probability? And the main point we found was that it's not well calibrated, but we're not intending to use it to assign risk. We're using it simply to sort highest to lowest risk. So calibration becomes less relevant in that setting, which is called a micro-allocation setting. So great questions. I'd be happy to engage with you. Feel free to drop me an email.
All right, this next one is for Dr. Flynn. It seems you're making model and knowledge artifacts synonymous, yet knowledge artifacts, especially executable, would include more than just the model. Or is the model meant to encompass all that goes into an artifact?
Yeah, thank you for the question. Yeah, you're absolutely correct that in this presentation, I'm using those terms interchangeably, really to be as invitational as possible and communicate across different concepts that people have for some of the same things. So some of the work going on in the MCBK, or Mobilizing Computable Biomedical Knowledge community, targets this challenge of being able to say precisely what we mean by these various terms, but that work is formative and just coming along now. So one person's model is another person's artifact, sometimes compound artifacts with a variety of instructions and other files and things that would go along with some software code that encodes computable biomedical knowledge can be wrapped up and thought of as a single artifact. And so there's some complexity there that I think still needs to be worked on and ironed out so that we can speak precisely and get down to terms that everybody can understand. But again, thank you for the question. It's ongoing work as far as I can tell.
This next question is for Dr. Sales. Typically, how quickly would you update these learning treatment teams? I'm familiar with PDSA process, and I'm wondering how quickly these learning cycles turn over and continue to refine the process to improve outcomes.
I think that's a really good question. I think a lot would depend on the strategies that people are using. So for example, in the first strategy that I mentioned, the rapid educational components, I think you'd want to evaluate on a daily basis by walking around rounds and checking to see whether people are actually using the information or not. And I think as you get deeper into the cycles and you move from the first rapid iteration of a strategy into the opportunity perhaps to broaden out and use broader diffusion strategies or things that perhaps deepen the knowledge and deepen the learning, you would then be able to evaluate those at probably still rapid cycle, but not necessarily on a daily basis. You might be doing it, every few days. I think one of the keys is in this kind of rapid, pressured, highly time-constrained situations with a surge pending, people really very concerned that, tomorrow or the next day, there are going to be more patients than we can take care of in our hospital. The rapidity of the cycling has to be very, very high. And as the surge has evened out and flattened out, I think we've been able to think about doing things on a longer term basis and address some of the more long-term questions, as I said, around issues around autonomy, clinical judgment, where clinicians should think about using judgment versus looking at the score and making decisions predominantly around the score. Thanks.
Dr. Sales, this one is for you as well. How do you unleash the intrinsic motivation for frontline providers to use the deterioration index in the context of so many competing priorities? Is audit and feedback a good strategy in this situation? Thanks,
Mihaela. I have to say that I appreciate you asking that question. I think audit with feedback would be useful. The thing that I'd say though is, as you know, and some other folks who know me know, I think we have to design feedback reports carefully, but we wouldn't have the time to do that in this situation. And so, in fact, what people were getting was a form of feedback based on the deterioration index itself and how it was being used. So I think that the intrinsic motivation though is the key, and that was the thing that I really came through most strongly. And Karandeep actually had a version of his slides in which he highlighted that. But the degree to which people felt genuinely motivated to respond to a crisis was huge. And as a result, it's the situation in this case that really unleashed that intrinsic motivation. We can't rely on that in other situations. And as pandemics and surges die down, people's fatigue and pressure come back. And I think that the question becomes, how can we keep people motivated at a level that's appropriate and reasonable? Thanks.
Okay, this next one is an ethics question for Dr. Platt. Do you start and learn early, or do you wait and try to get it right the first time? It seems the iterative cycle proposed biases you to start and learn. how do you modulate this drive bias?
It's a great question. And I guess I don't know. The answer is, I think, it just depends. So Chuck started out the very beginning of the presentation saying that the ethics piece would remind us all that this is ultimately a human system. And so I think it's really up to the people that are going to engage in a learning cycle or learning cycles to decide sort of when it's time to move from one stage to the next. I think it's a good sort of check on a group, on a learning community that's engaged in learning to modulate that that drive or bias to ensure that you're not acting prematurely, but that you're also striving to learn and improve, which implies doing something.
All right, thank you. This next question is an overall question for Dr. Friedman. Is this learning health system operational, and what data is being fed back into the loop?
Thank you. As I said in my opening remarks, this presentation is a combination of things that did happen, and I think you received a pretty vivid portrayal of the rapid learning system that was deployed. And in addition, a number of observations were offered about what might, in the presence of a more mature learning health system, be possible. So I think we are witnessing a phenomenon that arrived quickly, required a very, very rapid response, which took place. It was a data-driven response, as you heard from Karen Deep. It resulted in an intervention that it turned out was not necessary, because we did not have to deploy the field hospital that was anticipated. What's persistent here, and I hope I'm not overinterpreting your question, is an infrastructure, and we didn't emphasize in this presentation another key feature of learning health systems, and that is a persistent infrastructure that can support learning health systems, that can support multiple learning cycles ongoing simultaneously. So when you talk about whether this system still exists, this really takes me to this concept of infrastructure supporting learning cycles. And if we really are going to realize the kind of learning health systems that not just this nation, but the entire world needs to deal with these kinds of challenges in the future, we have to think about infrastructures, and these infrastructures have to be persistent, even though the learning cycles that they support may come and go over time. Thank you for that question.
Okay, we have another question about stakeholder engagement. What can your team share about engaging patients in a learning community? Has the pandemic changed the way you think about bringing the patient voice to the table? And if so, how? And maybe Dr. Sales or Dr. Singh, one of you could take that first.
Well, I'd be happy to start, but I'll keep it brief. I think this is a really challenging question, and the issue in the pandemic in particular is that by the time many patients got to the hospital, they were so sick that their voice was muted. I think, though, that's only part of the answer, because most people had family members with them. But again, the conditions of this meant the families couldn't stay with their loved ones. And I think that you're raising a really important issue that is not part of what we've been talking about and thinking about in the presentations at this point. but one that would definitely need to be considered as this piece plays out and as we move into sort of normalizing the current situation and figuring out how to do this better. Thanks.
Yeah, so I'll just add to that, I think we have a lot of work to do. I think what's changed for me maybe with the pandemic is really just thinking more about which patients are we talking about? Are we talking about the predominantly Black patients with COVID-19 who are, getting sick, their family members are getting sick? Or are we talking about the kind of patients that our usual patient population, I'll put usual in quotes, that is not able to get their surgery done for, cancer or other things because that was kind of put on hold from a standpoint of public safety. So I think we just have to be very inclusive in how we think about everyone who this kind of situation affects. And there's probably not a right answer on, what is the right thing to do, which is why a lot of the decisions were just driven more from a public safety standpoint than they were from an individual one-on-one patient standpoint. But I think absolutely we need to be engaging patients and understanding their concerns to the best that we can.
Wonderful. Thanks everyone for your talks as well as for the questions. We've had a lot of engagement with the participants, and there's at least, a handful of questions that still have yet to be answered. As part of the distribution after of the, not only the slides and the video, we'll make sure that the answers get posted as well. So next slide, please. I want to, with the sort of 15 minutes or so that's left, next slide, bring in our panel of experts, or additional experts, if you will, to really think about what does this all mean, right? What is this learning health system? How do we construct it? There's a lot of data questions, there's a lot of ethics questions, there's definitely questions about who is and who isn't included in an LHS and the data capture. And there's also sort of the right use of patients' data at the right time. So I want to bring in Drs. Ray DeVries, Zach Landis-Lewitz, Gretchen Pyatt, and Vinod Vidiswaran to kind of put things all together for us. You're going to see me looking over at the Q&A because there are a few questions and answers, but Gretchen popped up, so I would love to hand it over to you to start with to just kind of put things together from your perspective.
Yeah, so I think that the presentations that we heard today really do a nice job of encapsulating what it means to have a learning health system and to go around the learning health cycle. One of the questions that I saw pop up in the Q&A was that, was the one about how are the data fed back in. And one of the things that we didn't, or I would say Anne didn't get a chance to really go into a lot of detail about, was that, when you do implementation, you are also generating a significant amount of evaluation data because you're evaluating everything that's happening. You're evaluating the reach and the feasibility and the acceptability and the satisfaction with all of these different efforts that are happening. And that data then, those data are able to then circle back in and feed back into that cycle to inform other questions that need to be studied with the learning cycle. So even though there wasn't a field hospital that came to fruition, thank goodness, right? We could still take that evaluation data from the implementation part of the cycle and use that to understand further questions about, intensive care and how people with COVID are treated in the health system.
Everyone knows I'm a big talker, and so I didn't unmute, which was a problem. But Zach Landis-Lewis, I wanted to bring you in on this conversation because when we looked at the EPIC deterioration index and how it's represented, I was hoping that you could talk a little bit about data representation and how people understand that and use that to make decisions. There's a number of questions about, okay, so you have this information, but what does it mean? How do you teach people to use it in a way that's meaningful and helpful to patients?
Thank you, Karen. I want to think about that. How do people use and make sense of that information in the context of an important problem that's related to the use of models like the Epic Deterioration Index. And as we add more and more of these models, we need to recognize that information chaos is a challenge for clinicians that's routinely experienced, both in terms of information overload, too many sources of data, and in terms of missing information and inadequate information to make good decisions and to provide the best practice. And so an important question then, as we learn about the validity of the deterioration index and other models and make decisions about how we're going to present these, how we're going to deliver that information, which Anne showed us in this kind of dashboard presentation. An important question then is, how do we do that without worsening information chaos? And user-centered design methods, I think, are something important to recognize as approaches that we can help us to learn about the optimal ingredients that we put into these tools, and we can think about that as designing both the experience that people have as well as the resources and tools they use. And as we learn through user-centered design about the fit between what people need and what information we have, I think there's a lot of ways in which we build generalizable models and enduring expectations of what people need, so that in the context of a pandemic, we're not starting from scratch and getting started in terms of even thinking about what's ethical. How do we deliver this quickly? We already have, hopefully, a good understanding of who the user is, what information they need, and how they're going to use this kind of tool. So those methods also help us to recognize when there are important differences in populations, across contexts, across clinicians. And I think there's a growing need to tailor how we deliver these interventions, how we do this kind of communication. And as we implement more and more models like the deterioration index, there's a growing need for us to automate how we present that and collect new sources of data so that we have additional kinds of feedback to know, are our interventions actually changing clinicians' awareness? Are they influencing decisions? Are they helping clinicians to practice better? So I think that's an important future direction for learning health systems.
Yeah, agreed. There are a number of questions about sort of what data goes into a model and how does that data get chosen? How does it feed back? So I wanted to bring Vinod in to really think about, the data behind the options, the actions, and how do things get included or excluded from a model. So there was a question about genomics. There's a question about which patients when, and once COVID passes, we're not going to have enough COVID patients per se to fill the model. So if you could speak to that, that would be really helpful.
Sure. Thanks, Karen, for the question. So reflecting on the data to knowledge piece, what we've kind of shown is, in this particular case, it was a deployment of an existing model where really the model was used before knowing whether it would be helpful for identifying risky COVID-19 patients. As Karandeep said, there were other models that were also evaluated, like Epic sepsis model, and then the decision was made to kind of go with a model that performs relatively well, with the understanding of how the model works, even though the model itself was not clear. So in this particular implementation of the learning cycle, a new model was not created based on existing data. However, this data integration and training is a critical component of the learning cycle. And even with the existing model, it will be interesting to kind of see how this model understood or was deployed when there were other comorbidities that were associated with COVID-19. Or once we know that there are specific information about patients' health history that could have been indicative or helpful in your overall model, how can we improve existing models to learn in a quick iterative sense, almost like learning the model as you go along, so that we can model our patients better, or we can use this model in a much more effective way. This, of course, needs the models to be computable and available, right? One of the biggest challenges of EPIC deterioration index was that the model itself was proprietary and not really well known, really, the intricacies of the model. So the kind of linking our data to knowledge piece to persisting computable knowledge, it is important to kind of highlight what assumptions were made when the models were created, and how those assumptions might be valid or not valid when it is deployed. It is very common now to have existing models be reused in different scenarios, especially when you have a time constraint, or when there is trust built into how a model works. There is a comfort level that comes with the model, and then it gets higher kind of availability to be used in other scenarios. However, and so that kind of talks to what Jody talked about, trustworthiness with models and with systems. However, it is kind of important to highlight the limitations of those models, especially when it is being used in different communities than what it is trained on, like underprivileged communities or communities that have different comorbidities associated with a particular condition. So I think that that is kind of the power of using these learning cycles, so that we can learn from an existing implementation, but quickly feed back into the second loop or around the cycle to kind of learn from this specific instance in this specific learning community and how you could improve the model or make it better.
Yeah, I just wanted to jump in, and thanks, Vinod, for sort of setting that up. I wanted to jump in and say, we know that there's many, many things that can go into a model, but there's also many, many things that can never get into a model. And unfortunately, it's a lot of those things that are pushing the results that we're seeing in a lot of different populations, mostly those of color, in the COVID pandemic. And, regardless of how great the data are that may go into a model, if we can't hear from the people who have had COVID, who have recovered from it, from their family members, in order to learn from their experiences and to better understand their healthcare experiences and the shortcomings of our health system, not just Michigan Medicine, but the health system in general, we can never really get a 100% accurate look at how the data are explaining the care that's happening. So I think that's a really important piece. And I think that when we think about the learning community, and you all heard Chuck talk a bit about the learning community right at the beginning, and then the question came up in the chat or the Q&A about how do patients, where do patients fit into all of this? It's really, really important then when we're forming learning communities, not just around COVID, but around any health problem of interest, that patients do have a voice, because we need to learn from them. And we need to learn about the things that we are never going to learn about from the electronic health record. So I just wanted to throw that out there, and happy to hear others' opinions on that.
Yeah, thanks, Gretchen. That actually is a perfect lead-in for Ray DeVries, who has already popped up. So I'm not even going to give a lead-in because I know where you're headed, Ray. And so please close us out here. This is great.
Yeah, thank you. Thank you, Gretchen, and thanks to all my colleagues for this great presentation. I think from an ethics point of view, it's fair to say that we're facing two crises in our country now. The pandemic crisis, which, as Gretchen pointed out, also made evident the kind of structural racism that exists in our society and how it affects health. And in case you hadn't noticed, the most recent crisis with the murder of George Floyd that made that structural racism so apparent. So these are the reasons. I think in Dr. Platt's presentation, she talked about the fact that we need an ethics in a health system to sort out the questions of how you develop a learning health system, how you apply the deterioration index, when do you apply it? Those are really important questions, but we also need an ethics of health systems. And if you look at what's been going on with ethics work during the pandemic, I'd have to say the majority of it focused on really important questions about how do you allocate scarce resources, which is more or less what the EDI was also suggesting. How do you allocate vents? How do you allocate ICU beds? Less time was spent on questions of justice or injustice that resulted in the inordinate amount of infections and deaths in vulnerable communities, Black communities, and also nursing homes where there's been an incredibly inordinate number of deaths. And there is, I want to say there's some overlap between those two approaches. I mean, if you think about the ethics of balancing individual autonomy with the needs of a community, and you have to ask whose autonomy, which communities. There's the ethics of using a proprietary model, as Karen Deep brought up. I mean, we need money to fund the creation of these models, but it's the patients who provide their data. Do we really have to charge for those? And what does that mean for accessibility of these models? There's the ethics of data collection, not just in the representativeness of the data, whose data are in the model, but also the very collection of data. What does that mean for relationships between caregivers and patients, as Ann Sales brought up, or what does it mean for representation? And so you might say, so how can an LHS help? And I've been thinking about that as we were preparing this seminar. And I was reminded of some work done by sociologist Eric Klinenberg, who tried to understand the inordinate number of deaths in the heat wave in Chicago in the 1990s. And what he said is we need to do a social autopsy. We need to peel back the skin of society to understand why these people died. And I think in listening to my colleagues talk, I think there's room here from an ethics point of view for creating a social deterioration index to understand and hopefully correct the kind of conditions that increase the likelihood of certain populations suffering from this particular pandemic. And that now, as we're thinking about all the riots going on in the country, suffering inordinately in other ways in our society. So I do think a learning health system should and could think about that. How can we create a social deterioration index that looks at the society and not just at individual patients? I think that's a challenge for us who work in ethics, and I hope my colleagues in the field of bioethics take that up.
Yeah, Ray, such important points. And I really am resonating around the social deterioration index, because with all of the uprisings and really the attempts to raise consciousness again and again and again about whatever learning community we're talking about, gun violence, systemic racism, et cetera, we somehow still don't manage to close the loop yet, to learn and to re-engage and to make change. So we've got our work cut out for us for sure. And somehow we have gotten through 90 minutes, which I cannot believe. Can we get to the next slide, please? Thank you. One more as well. I just want to take a moment really to thank everyone, not only for your participation being here, but there are so many people behind the scenes that made and helped this webinar happen that I can't even begin to list. But I really want to thank my colleagues who came together in a very short period of time, not only, you know, in a clinical sense, but also in this collaborative sense to really work together to say, you know, this is what we mean when we say learning health system. And this is what we mean when we're talking about a loop and a learning loop. So if this has interested you and piqued your interest to continue the discussion, we want to let you know that we're going to have another LHS COVID-19 webinar realizing a global LHS for COVID-19 that will include lessons from Italy, Spain, and the United States. So look for an announcement for that and save the time and date, which is July 29th at 10 in the morning Eastern time. If you have any questions or you want to connect with us or you want to learn more about our programs, our educational degree programs, there's contact information below. You know, the goal of the Department of Learning Health Sciences, as you see, is revolutionizing learning and transforming health. It's really a privilege and an honor to be part of this department. And I just wanted to thank you all for taking time to listen to us today. So with that, I'm Karen Stahlberg, and I'm going to close this out and just say thank you again. Stay safe, stay healthy, stay engaged, and always go blue. Thanks.